Thanks again for inviting me here for the tools and technology seminar. And yeah, so my talk today is about Prima, learning neuroimaging models from health system scale data. So here's just a brief table of content for my talk today. So I would like to start by talking about like the motivation behind like training an AI model for brain MRIs. So basically, like, why do we even need a neuroimaging model that can read brain MRIs, and what are some of the existing challenges of like training one, right? So okay, so what are brain MRIs? So brain MRIs are like these 3D scans. That's like nowadays it's like an indispensable like diagnostic tool for a lot of like brain diseases. Like we show some examples here, like if you have a brain tumor or if you have some brain infection, or if you have like brain developmental problems or like blood vessel problems, then you would probably want to like and then like you would probably be ordered to take like a brain MRI. And brain MRI has like lots of advantages, right? It gives like a comprehensive view of brain structure in 3D, and it has like excellent soft tissue contrast that can show like these brain structures often better than CTs. It's often used to guide treatment decisions, and most importantly, it's like non-invasive and safe. So like when you take a brain MRI, you don't actually cut open your brain, and also like it's not there's no ionizing radiation, so you can just take it repeatedly without like worry about increasing your chance of getting cancer or something. Um, so Okay, so now I would like to show you all what do you actually get, right? So let's say a patient was ordered to take a brain MRI, then he goes into that room, gets scanned by the machine, and what do they actually get out of there, right? So so as we all know, each brain MRI 3D sequence is like this 3D structure. Actually, I'd like to show one example here. Let's see. Yeah. So one 3D sequence is like this 3D structure that you get out of like a brain MRI. So you can imagine like this is like a taken from like the top of the head like this and then scroll downwards like that. So you can see like how it's like each of these is a 2D image, but you stack them together vertically. You can see like this is a dense 3D structure that shows like the brain, right? This guy has a big tumor here, by the way. But like basically this is what a brain MRI would look like for a patient. Um, okay, so now let me go back to the slides. Sorry. Uh, There. Okay. But when one patient goes to take a brain MRI study, right, he doesn't just get scanned once. Instead, he actually gets scanned many times, right? So, and then when you go out of the room, you'll end up with like a bunch of 3D scans. So each 3D scan might have a different sequence type, right? So it could be T1 weighted or T2 weighted or flare DWI, and then some other types. And they're just like basically scanned with like different contrast or weighting, so that like they're often used to diagnose different types of diseases. And also these scans can be in different orientations, right? They can be taken axial, which means like you scan from the top to the bottom of the head. It could be sagittal, which means you scan from side to side, and then it could be coronal, which means you scan from front to back, right? So, and all of these scans together form like one entire brain MRI study, right? So we would call all of these as one study, and basically when a patient goes to take a brain MRI study, this is what they get, like a lot of 3D scans, and that this is what the radiologist will try to read when they try to give a radiologist report. They would read the whole study and then write some report on that. They wouldn't just look at one single scan. So here's the recent trends on the number of brain MRI studies taken from our taken from like our University of Michigan Health System's own PAC system. That's our database. And we can see that like the number of brain MRIs being taken each year is actually growing exponentially. It's like doubling every 6 years. So, but as a result, since we don't actually train enough radiologists to cope with this exponential growth, right? As a result, and especially in more recent years, we can see that like the average turnaround time for patients is just going higher and higher. By turnaround time, I mean just the amount of time a patient has to wait between when they take the study and when they get some radiologist report from a trained radiologist, right? This is problematic because like as we know, like the longer you have to wait, the more likely like your well, so in some for some, especially for some kind of some of the treatments, you actually the urgency is pretty important. So the longer you have to wait, the worse the clinical care quality is going to be, right? So that's a problem that's actually like a real world problem we need to address. And also as a result of this radiologist shortage, right? So we also found that there is actually bias in turnaround time within the health system for people living in like different counties, right? So basically what we found is that like so here down here we're actually showing what how much more likely do you have to wait at least 1 week before you get your results back, right? And we do see that if you live in like certain counties, like if you live in populous counties, you're actually like 2.5 times as likely to have to wait at least 1 week before you get your report back compared to like if you live in like more populous regions. Um, Similarly, like if you live like in northwest in a county in northwest Michigan, you're 4.5 times more likely to have to wait at least 1 week compared to southeast Michigan, which is where we are right now. Um, and also this also depends on like we also found that if you take your MRI on a weekend, you're twice as likely to have to wait at least 1 week. Now that might make sense because radiologists don't work on weekends, but still like you don't get to control what day you get a brain problem, right? So it's still sort of unfair. Um Sorry. So okay, so we've talked about the current problems of radiologist shortage and unfairness in turnaround time across different groups of people. And we believe that training neuroimaging AI models can help alleviate these problems, right? So we would like to train an AI model that basically takes in a whole study, which contains many 3D sequences, right? We give it to the AI model. Then we want the AI model to make some automated diagnosis. So the AI model will be able to tell us, oh, this guy has like a brain tumor, like a meningioma or something like that, right? But just having these predictions is not good enough because, as we all know, like when an actual radiologist says, oh, you have a tumor, like people ask like, okay, where is it, right? So like the radiologist will just point it out in the scan, say like, oh, like here it is, right in the middle, right here. You can see this big white thing. Um, so we would like our AI model to be able to do the same. We want its like prediction to be explainable and trustworthy. So for example, like here, like we would want its prediction of meningioma to be able to actually contain a highlighting of like or visualization of like the region in the MRI scans that actually shows like where this tumor is. Right. Like this will make the AI model a lot more trustworthy and more usable to actual patients and radiologists. And in addition to just like disease prediction. We also want the model to be able to do something called worklist prioritization. Right. So right now, sort of how radiologists works is they just get all of their studies assigned to them in random order, and then but like as we know, like for some patients like problems might be more urgent than others. Right. Like if you have a hemorrhage, you probably want to get that treated as soon as possible versus if you don't have a problem or term tumor or something, like it's not that you don't need urgent treatment, but like waiting a few more hours doesn't really matter that much. So basically, what we're trying to do here is that we would like to have our AI model automatically assign like a sort of acuity or urgency score for every single brain MRI study, so that like basically like when so that basically like we can assign the more urgent ones to radiologists first. So this way we can improve overall clinical care for patients. And lastly, so one other thing radiologists people rely on radiologists to do nowadays is like this referral process, which means like after so basically after a patient gets a radiology report, they have to be referred to a certain department for like further treatment, right? And we would like our AI model to be able to perform automated referral as well. So maybe we can give some referral recommendations faster so that patients can maybe get their referrals scheduled earlier. Okay, so these are just some ways AI models can help. So if AI models can help in so many ways, why haven't anyone trained like a real good model for this yet, right? That's because like there are actually several major challenges in training AI models for whole study brain MRIs. And the first challenge is basically like these whole study brain MRIs are massive and very complex data structure. Right, as we've shown before, each brain MRI study contains not just one but many 3D sequences, right? And these sequences are not standardized. They have different sequence types. They have different sequence orientations, and they have different sizes in all three dimensions, which makes like just training AI models a lot more challenging, right? And on average, a single whole study can contain over 1,600 2D slices, which is like so if you think about like these like modern like computer science or AI models for those natural photos, they just take in one photo at a time and then deal with it. Now in this case, we have to deal with over 1,600 like 2D photos at once, and and like some of the diseases we're looking for might only occur on a few of those slices out of all these thousand slices. So it's a really like this data complexity is what makes the modeling problem really challenging. And the other major challenge in like training an AI model is basically the lack of publicly available data, especially the whole study ones, right? So it's actually very hard to curate like a public available like brain MRI data sets, mostly due to privacy concerns, because it's actually a brain MRI 3D scan of the head, which means if you just stack them together and put them in a 3D space, you can actually reconstruct the person's face. So if you don't process them, you it'll be like you're gonna get sued. Yeah, so that's one of the reasons why publicly available data is very, very scarce. And also like most publicly available brain MRI data sets are just single sequence, like they only take T1 scans or they only take like T2 scans or FLAIR. So and then they're also not very big, right? Just because of the difficulty and like have to blur the face and everything. So they only contain at most like thousands or tens of thousands of 3D sequences, which is like not nearly enough for like training a good AI foundation model, right? Like more all like for they all really need like a lot of data to do this. Okay, so basically in my work, I aim to tackle these challenges through well I plan to tackle a whole study data complexity through data standardization and compression, and we also design a very efficient modeling structure, which I will talk about in a later parts of the talk. And we address the lack of publicly available data by curating a much larger data set called UM220K with paired radiologist reports. So each study comes with the actual radiologist report, like written by an actual radiologist in the real world, from our University of Michigan health system. And we will, for the next section of the talk, we will just go over this data set in detail. Okay, so basically how we curate did this data set is that we just queried all brain MRIs from our U of M health system before May 31st, 2023. And then we just performed some filtering, like so we want each study to have paired radiologist reports, so we only take the ones that has radiologist reports. And then we have some additional criteria like the metadata has to be uncorrupted and so on. And at the end we end up with a 221147 uh whole studies, and that includes 5.6 million 3D sequences. Remember, each study has many 3D sequences, and then that is equivalent to 362 million 2D slices. And this data set is basically like 70 times larger than recent like so-called neural foundation models being published. So it's a very, very big data set. And here are just some high-level demographics of the data set. As we can see, like we are definitely collecting more data from like more recent years because there's just more brain MRI being taken. But the distribution across the months of the year or like across gender is generally pretty fair. And like on the right, we just show the top 20 imaging centers where we source our brain MRI data from. As we can see, it's like distributed all over the state of Michigan. Okay, so now we have these studies, right? We would like to get a set of like ground truth diagnostic labeling, like whether each study has a certain disease or not, right? So we manually define 63 diagnoses across 15 categories, and we show the categories on the right. And basically here we show the number of MRI studies that have at least one diagnosis in each of these categories. And here we show the distribution within each category for each of the diagnoses. And as we can see, like these diagnoses are not really evenly distributed, so not all diseases have the same number of studies on them, which is fine because that's just how the real world works, right? Like not all disease gets the same no, like gets the same number of patients. So yeah, so we get these labels, bypassing our ground truth radiologist report to like GPT-4. Back then GPT-5 didn't exist yet, so we just have to do GPT-4. And basically we'll give a report just asking like, okay, does this report say that this person has this problem? And overall, we think we found that GPT-4's labeling is actually pretty accurate. So all right, let's move on. Okay, so one more data curation thing we did was this report summarization. Right, so on the left here we show what we show like an actual real whole like radiologist report. Right, we blurred out like these dates and stuff, but we didn't actually change any other words. As you can see, it's a very long report, right? So which means like if we directly try to train our models with these long reports, it's gonna be sort of computationally inefficient. And these reports contain a lot of like normal descriptions, right? Like over here it says no acute intracranial hemorrhage, the ventricular system is normal without something something, and then no something something, and so on, right? I mean, like these things we generally found that they're not very informative for training an AI model on them. So it's best if we can somehow get rid of them. And also another problem with like directly training with these long reports is that like these long reports are directly written by the human radiologist, which means they might contain some writing style aspect specific to certain radiologists, right? And we don't want the model to somehow cheat by matching the writing style of like the reports versus like some, I don't know, hospital specific feature in the brain MRIs, and then instead of like focusing on the actual relevant clinical features, right? And also like these reports sometimes contain unwanted identifiers like radiologist's name or date of examination, which we definitely don't want to expose the model to. So that's why we have to perform a round of report summarization, which means we use a GPT 3.5 Turbo to summarize the report through 3 steps. Right? First, we ask it to summarize the report into enumerated items, and then we would remove all of those sort of normal descriptions, and then we want to like remove those unwanted descriptions of comparisons to previous studies. So what that last step means is sometimes the radiologist report will say, oh, in comparison to the previous study, blah, blah, blah. But when we're training an AI model, we're only given the current study. We don't actually give it the previous study, right? So those descriptions actually would make no sense to the AI model. So we would want to get rid of those as well. Um, so yeah, so as shown on the right here, so that really long radiologist report after GPT 3.5 summarization, we end up with a very nice and concise and itemized summarized report that's like just shown down here. It actually captures all the important parts of the report, but now it's much shorter and better for training. And we'll show that it's actually better for training in this slide, where we basically take like a clip-trained language model to like encode each of those to encode long and short reports, and then we plot them with t-SNE plots, and then we color them by whether the report says the person had a certain disease or not, right? And then as we can see, like in the gray dots on the left here, which means the encodings of the summarized reports, they're actually much more separable than like the encodings of the full reports, right? That just means that it's easier for the model to pick up like whether a person has a certain disease or not using the summarized report compared to using the long reports, right? So that's why we decided to use summarized reports to train our main model instead of the long reports.
Question.
Yes.
Let me go back one. I've been trying to read these statements. I can't find any mention of metastases. Is it there someplace obvious?
There's you mean the summaries? I think we said metastatic
The
deposit.
number one finding is metastatic tumor, presumably. It says brain mets in the buried in the second line as the lung cancer has brain mets.
Oh,
It's from history.
yeah,
Where is it?
there's one more part down here in impression. It says stable metastatic deposit at the left side of the superior cerebellum.
Is it in the description somewhere there?
Yeah,
it's red. In red? Hyper intense.
Yeah, maybe this one will be bigger. Yeah, so actually this red part's mentioned twice. So like there's a part up here and then there's another red part down here. And the summarized report, we sort of just summarized the two of them into
So
one.
down here is the impression.
Yeah.
Description. It's about patchily, whatever that is.
Uh-huh. Oh yeah,
Signals. That's what the tumor looks like.
right.
Okay.
Yeah, we sort of uh yeah, I think we sort of just summarized that part out. Probably because like the model probably looked at this without evidence part and decided to just leave this part out. So yeah, sometimes the summary we will lose a little bit of the granularity in there.
Yeah, I don't see about the cerebellar vermis. I don't see that.
Oh, that's down here.
That's the impression, but where is it in the description?
Um,
Dr. Holman, the short answer is that it's not really there. The unfortunate part about these reports is that it's quite a noisy approximation of the findings that are actually in the image. It's up to the radiologist to dictate whatever they think is appropriate. But there's not a standardization in terms of naming the exact anatomic location of the suspected selected diagnosis, whether this is a change. It's really just someone dictating the microphone. So you can see, even you picked up rightly, there's an inconsistency between the findings and the impression, which is quite worrisome as a data scientist.
Yeah.
So anyways, that was part of the reason that you came up with the summarizations, because we need to have a way to standardize these findings to allow them all to learn because they're quite easy.
Just one other follow-up question. How do you determine like what's, you said that the negative data was, or the negative findings were like taken out, but sometimes in medicine, they have what they call like pertinent negatives, just when you're considering like a broader differential that is pertinent, but maybe it doesn't matter to the model. Is that what you're trying to do?
um, in some sense, yes. So yeah, I agree that like in actual medical settings, like saying that this person doesn't have something is actually important. But just for our as I'll show in some of the later slides for when I actually train the models through what we call like a clip objective, what we found is that like including these these normal statements can really confuse up the model, right? Because to a language model, like to a computer who actually looks like these texts in like characters or tokens, right? Saying like a statement that says no meningioma found versus meningioma found, they're actually really close to each other, like character wise, right? So sometimes these can really confuse up the model, and so that's part of the reason why we think that removing these extra noise could serve better just for training the AI model. Yeah, I'm not saying that like radiologists should just do summarized reports to patients. No, that's not acceptable. But we did this summarization mostly just for the model training purpose.
Thank you.
Yep. All right, so we will move on. So yeah, so in summary, our UM220K data set contains a lot of data. It's over 220K brain MRI whole studies. We have the pair radiologist report for each study, and we have the ground truth diagnostic labels by GPT-4 for each study. And that's over 63 diagnoses and from 15 categories. Okay, so now we have this big data set. We're actually going to train our model on it. And next, I'm going to introduce how our model works. Um, so basically, here I'm just going to briefly show like the overall visual encoder pipeline for our for Prima, which is the name of our model. So basically, we would have the brain MRI whole study, right, which contains many 3D sequences. We'd first perform tokenization. We would first perform like a tokenization step. So since later on we're using the vision transformer as like our main backbone, right? And usually vision transformers require breaking down the each visual into like smaller parts to be fed into the vision transformer one by one. So basically here what we do is that we would break each 3D volume down into tokens of size 4 by 32 by 32, right? So as we all know, like these 3D sequences, they're like basically a stacked 2D images, right? So and the 2D images usually have like we have much higher resolution along the 2D slice axes compared to like the stacking axes, right? So that's why our volume token has size 4 by 32 by 32. So we have higher resolution on the X and Y, which is where this image slices are, and then we have a smaller resolution on the stacking Z dimension. So we would basically the first step we do is we just cut up the volumes into these small 4 by 32 by 32 tokens. And then yeah, and then what we need to do, and then for the next step, we're going to do a VQVAE compression. So why do we need to do this compression step? Well, that's because like this whole study, as we mentioned before, this whole study is very complex and has a lot of data, right? And it often contains over 20 3D sequences and thousands of tokens. And each token right now is 4 by 32 by 32, which means it's 4096 voxels in total. And this is very big, right? And feeding all of this into a vision transformer can just take up a lot of memory. So in order to like alleviate this problem, we do like a VQVAE token level VQVAE compression, right? So for the sake of time, we cannot go into details about how the vector quantization works in VQVAE, but on a high level, basically what a VQVAE does is that you would train an encoder model that takes in the original 4096 dimension token, and then like you would encode it into a much smaller lattice space. In our case, it would be 256, so it's like a 16 times compression, right? And then we also train a decoder that is able to reconstruct the original token from the smaller compressed token. And then like we would jointly train the encoder and decoder together with like a reconstruction objective. Yes.
Yes, just a quick question. So since the images are acquired on different scanners following different protocols, so they have different acquisition parameters. For example, like they have different slice thickness
Yes.
and then the gap. So giving the same token, does that mean that actually for different images applied on different based on different protocols, the number of voxels won't be uniform?
So we actually like perform some resizing before we do the tokenization. We would resize everything to the X and Y so each slice will be resized to 256 by 256. And in the Z dimension, we standardize to 4 millimeter between two slices. But then when we tokenize, we always do 4 by 32 by 32. So yes, it's true that like for different sequences, since the total Z dimension might still be different, you might still have different number of tokens per sequence. But 4 by 32 by 32. Okay. Yeah, and then basically after we train this encoder and decoder with this reconstructive loss, we can simply take the small latent compressed token as like the compressed version of our original token, because if the decoder is able to reconstruct the original token from the latent token, that means the compressed token should contain all the information from the original token, right? And so here's just a detailed illustration of how we train this VQVAE model. So just as like a sort of a data or augmentation step, right? Since our brain scans are actually come from all three orientations, we just permute the orientation of each of our token when we're training the VQVAE, just to make the model a little bit more robust. But yeah, as we can see here, we would feed the raw tokens into our 3D encoder for 16x compression rate. Then we have this latent, it generates these latent tokens, which are then feed to the Prima backbone. And we have this decoder that can take in latent tokens and then like reconstruct the no tokens. And as sorry, I'm not used to this Mac scrolling, keep scrolling backwards. Yeah, so here are just some examples of reconstruction by our VQVAE. So as we can see, our VQVAE actually like produced some pretty high quality reconstructions. So that means like our latent tokens should be good because it contains all the necessary information from the original token. Okay, so next I'm going to talk about like our main backbone, which is the hierarchical vision transformer. So the main architecture of our hierarchical vision transformer is vision transformers with registers. So here I'm just going to quickly illustrate what a vision transformer with registers are, right? So basically like here's how it works for like just regular 2D images, right? Just given like this 2D photo, so normally you would just cut it up into small patches like these, and they would feed them all into the transformer model, right? But in addition, we would also feed in a bunch of trainable registers together with these input patches to be fed into the transformer model. So these register space can just sort of give the vision transformer a bit more scratch space to work with. And at the end, we can just take the register outputs here as like the representation of the image. And there has been extensive research on this on 2D images that has shown that these registers really help improve model performance. And so our main visual backbone model is this two-level hierarchical vision transformer with registers, and we have a sequence VIT here that deal with tokens from each 3D sequence individually, right? And then like a study VIT that merges the sequence representations together to form like a study level representation. So basically, we start with these raw MRI studies, right? We first tokenize them into tokens. We feed them through our VQVAE compression to end up with the compressed tokens here, right? And then we feed all the tokens within each individual 3D sequence into our sequence VIT with these additional registers included, right? And then we do that for every single sequence. And then the sequence VIT will we'll take the register outputs of the sequence VIT and then merge them together using the study VIT. And then we take the final register output of the study VIT as like our final whole study representation with a single vector. So in addition to these visual tokens, we also have these sequence name and study descriptions available with each brain MRI study, right? And they can often convey very useful information. So for example, right here, this particular 3D sequence is called T1AX, which basically conveys that the study is taken in T1 weighting and it's done in axial direction, right? So in order to utilize these information, we train like a small 3-layer character level transformer as like the sequence name and study name encoders, and basically they would encode each of these names into just a single token, and then we would append them to all the other visual tokens when being fed into the sequence VIT and the study VIT. I think we'll have to skip this slide for the sake of time, but okay, so now let's talk about how we actually train the model, right? So we have this big we have this whole hierarchical vision transformer pipeline that encodes the whole study visual into just a single vector representation of the visual, right? But we also have these paired reports for each study, right? So we would feed them through like a language model to obtain like a text embedding for each one of these reports, the summarized reports. And then we would just apply clip objective between these two modalities, right? So basically like how this clip objective works is that it's a contrastive objective that basically tries to push the representation vectors of paired MRI study and report closer to each other. And then they try to push the representation of the MRI study and reports that do not match up. We push their representation apart. Right, so it's almost like teaching the model to match up the corresponding the MRI visuals and the corresponding reports. And in addition to the main clip loss, we also do like an additional auxiliary loss called patient discrimination loss. Basically, what it does is that so a lot of features will be shared across sequences of the same study, right? Because it's literally the same person, same head taken at the same time. So we want to somehow utilize this to improve training. And so basically, like how we do the patient discrimination loss is that we just take the sequence encoder and have them encode the sequences, and basically we try to push sequences from the same study to have closer representation from each other than sequences from other studies, right? Because other studies are different people or taken from different time, while for the sequences from the same study, it's really the same head. So, but just take weights. And we do find that like by doing this auxiliary loss, we are making the training the training convergence a lot faster. And so here we're comparing the blue line is our Prima model and orange line is just an ablation that where we don't do patient discrimination loss. And we found that like and the y-axis here is just some retrieval accuracy metric. And we see that like to reach the 30% on this metric, we're actually 5 times faster with patient discrimination loss, and we're to reach 40% retrieval accuracy, we're actually 6.5 times faster. So yeah, this additional auxiliary loss really helps with improving training efficiency. And before we start the big clip training, we would actually pre-train our text encoder on all of our reports just to get a bit more familiar on like these summarized reports. And we also jointly train the language model together with our vision model during the clip training. And on the right here, we show that like the blue line is what we're doing, and then green line is no pre-training, and red line is not trainable during clip. And we do see that like pre-training the text encoder helps, and but you still gotta be able to jointly train it during clip training. That's like the ideal setting.
So you consider that a big improvement?
The blue over green, it's
Slight.
kind of, yeah, it's not super big, but there still is improvement. So, and also we as we'll and also as we'll show later in the population studies, I also did this also translates to gains on downstream like prediction accuracy perform like increase and all of that. So yeah. Okay. So yeah, so then we just trained Prima on 8 L40S GPUs for 50 days over UM220K data set. And on the right, we just show like how the retrieval performance is going up over days of training. As we can see, it continues to go up over the 50 days, but towards the end, it's more or less flattening off. So so yeah, we just decided to stop there and start the evaluation. Okay. So yeah, so now we've trained this big Prima model for 50 days. Now we gotta evaluate on some downstream clinical tasks to show that like it's actually good and that's actually useful. Okay. So first we gotta have like a testing set. Right? So so in like healthcare and medicine, in a lot of research, they would do something called like a prospective testing, which means you would test your treatment method on some future patients, right? So we kind of want to simulate that a little bit here. So we collected this prospective test set data from the same source as UM220K, so from our University of Michigan health system database, but the test set is temporally separated. So it's like sort of from the future of the UM220K data set, right? So the UM220K data set is taken before May 31st, 2023. And then so our prospective test set is just taken from like the whole year after that. And we have like 29,435 studies with paired reports in our prospective test set. And we will basically do most of our like downstream task testing on the prospective test set to ensure that like we're not cheating by testing on training set. So, all right. So again, we will use GPT-4 to generate labels for these 63 clinical diagnoses for well, we did that for the training set. We're going to do that for the prospective test set as well. But what we do found is that like only 52 of the 63 has at least 220 positive samples in UM220K data set. So we do want these diagnoses to have at least 0.1% positive rate in our training set for us to be able to like properly evaluate the test for the testing performance to be reasonable rather than by chance, right? Because if a disease only shows up once or twice in the entire test set, then then like the performance reporting will be sort of unstable for that. So that's why like for all of our we're gonna do a 52 task diagnosis prediction. And there are actually two ways we can do this evaluation to evaluate our model. But since our model is clip trained, so two of the most common ways to evaluate clip trained models is MLP probing and zero shot. So by MLP probing, we mean like we would freeze the Prima visual encoder, right? And then we would fit like a 3-layer MLP. So MLP just means multi-layer perceptron. That's like the simplest neural network. We would fit a 3-layer MLP between Prima embeddings for a study, and each diagnosis we would fit them on UM220K, so the training data, and then we use the Prima and the trained MLP to inference on the prospective test set and report performance, right? So that's called MLP probing. But we can also do zero shot, which means there's no additional training going on. We don't train anything. We just predict directly with similarity between the Prima visual encoder output of a study and the text of the diagnosis encoded by the Prima text encoder. That's usually how people would do zero shot on like these large 2D image models. And we just follow the same protocol here for Prima evaluation. Okay. And then here we show the clinical diagnostics prediction results with zero shot. So on the right here, each column is a different model, and then each dot here represents one particular task. So each column should have 52 dots in total. And as we can see, like the Prima just does like way better than all of these baselines. So most of these baselines are actually just like 2D imaging coders. So we had to like run them on every single slice in the study, and then like we have to take max prediction logit over all slices for them to work properly. So as we can see, most of those baselines don't work that well. Most of them are around like around guessing performance. But Prima is like really doing well even when we do zero shots, so we're not actually training any model parameters. And here's just a more detailed breakdown on each task in a radar plot. Uh, as we can see, the outermost blue line here is Prima, and the inner lines are like the best performing model from like families of publicly available models. And we can see that Prima is really outperforming these baselines. And in addition, like we also did the MLP probing performance, right? As we can see here, the blue line, which is Prima, is still like outperforming the baselines by quite a bit. Now, but we do see that baselines actually do a lot better during MLP probing, and that's kind of expected because basically when you're doing MLP probing, you're sort of training the baselines, training their MLP heads on 220K data, which is like a very big training set, probably have more brain MRI information than these baselines ever had in their original pre-training. So that explains why they actually did much better during MLP probing compared to zero shot. But compared to Prima, like still Prima is like doing very good and still outperforming all of them by quite a bit. Um, okay, so all of the previous slides were about diagnosis prediction, right? And we also mentioned that we wanted Prima to be able to do worklist prioritization and referral recommendation, right? And here we show the results on those as well. So here we show so when we use Prima to do prioritization, we have Prima predict like a priority score for every single study, and basically the higher the priority score, the more Prima thinks that this thing is urgent, sort of. Um, and so we plot the distribution of the Prima priority scores versus the ground truth priority labels, and we do find that like Prima consistently assigns higher priority scores to studies that are actually more urgent or more acute. So that's good. And we also show the performance of the referral recommendation accuracy on a bunch of neurosurgery and neurology departments. And as we can see, the overall MAUC, the overall AUC performance on these referral prediction tasks are also pretty high. They're like in the high 80s and close to 90 for neurology. And in addition, we also tried to apply Prima to these so-called out-of-domain tasks. So by out of domain, we mean tasks like age prediction, dementia-related tasks, autism-related tasks, right? They're out of distribution because basically these things never occur in a radiologist report, right? The radiologist doesn't try to predict a person's age based on brain MRI or try to say if this guy has autism or not. So that's why we say these are out of distribution because like basically Prima never seen these kind of things during clip training. But we still take the embeddings from Prima and then we apply them to these tasks for MLP probing. And we do find that like the Prima features performance is actually pretty good. It's like even compared to like baselines that's specifically trained just for those out of domain tasks. And we also do pretty well on the age prediction. As we can see overall, our age prediction is pretty accurate. That was mean error of 5.6 years. So um yes, this just shows that Prima features are transferable to out-of-domain cases. Okay. So next, I'm going to show a set of ablation studies. So the first thing we're going to ablate on is just the data, right? We want to show that we actually need UM200K, this massive data set for Prima to work well. And we do find that, so we trained Prima with 10%, 20%, 50%, and 100% of UM220K. And we do see that like overall performance just like improving with more data we have. So that just show that having a big data set is important. Right, on the right here, we show the performance on each of the 52 diagnostic tasks with different amount of data, and the thick blue line is the mean, and as we can see, it actually keeps going up. Next, we're going to show some ablations on the model architecture, right? So the first set of ablations is we want to ablate on whether including the sequence name and the study description helps, right? So we do find that they help, but they're not essential. So like they only boosted performance by a little bit, which is actually good, right? Because we want to show that these things help, but we also don't want to show that like our model overly rely on these names of sequences rather than the actual visual features, right? So this is good. And then we also show that report summarization is important. As we can see, if we train with long reports, the performance drops by quite a bit. And then we also show that hierarchical vision transformer architecture is also essential because it works significantly better than baseline architectures like CNNs or other variations of non-hierarchical vision transformers. Okay. Lastly, I'd like to show a sequence type dropout analysis, right? So what we want to analyze, like what sequence types does Prima model rely on, right? So how we do this is that we would exclude certain sequence types from the input. And so we would delete, like, for example, all the T1s from all the studies, and then we just run the same Prima over and then have them make the predictions, right? And we find that first we find that like in most of the cases, deleting the so on the chart, right, the x-axis is actually just the 52 diagnosis, and y-axis shows like how much performance drop we get by removing a certain sequence type. So we do see that for overwhelming majority of the case, we do see a drop in performance after we remove like a sequence type, which is good, which means Prima effectively actually uses all types of sequences in each study, right? But we also show that like the drops are not very big, right? Most of the drops are actually less than 1% in AUC. So this is also good. This means like Prima is not overly reliant on any particular type. So like it would not be good if we remove T1, then all of a sudden all the performance goes to 50, right? That would not be good because that means like our model is overly reliant on T1, but now our model is shown to be not overly reliant on any one particular scan type. And for these particular diagnoses where we see very big drops in performance, right? These actually make sense because for example, for this purple line, which means we drop out flare, right? So these two diagnoses are edema and colloid cysts, and according to radiologists, they do look at flare when they try to make these diagnostics. So it makes sense that we will have big drops when we lose the flare modality, right? And the same thing here for meningioma and for intracranial hypotension. Like when we drop T1 contrast, we are seeing very big drops, and the T1 contrast is also what radiologists will look like when they try to diagnose these two diseases. So that also means that when Prima makes decisions, they more or less matches up with the behavior of like actual radiologists. Okay, so the next part I'm going to talk about is line visualizations, right? So remember I mentioned before that like not only do we want the model to be able to make predictions, but we also wanted to give make the predictions explainable and trustworthy, right? So we're going to use this method called LIME, right? So LIME is essentially a visualization method for explaining black box classifiers, and essentially what it does is that it assigns a score to each part of the inputs that indicates the part's contribution to the production. So here's just an example illustration on a 2D photo, right? This is a simple classification task called cats versus dogs. So we basically there's a trained classifier that basically tells whether a 2D image have a cat or a dog. And then this very tricky guy decides to like give the model a photo of both a dog and a cat. And if we run Lime visualization over this photo, we see that like it actually points out that okay, this green region is what is the part of the image that contributes the most to the cat prediction. And then this red region is the region with the least contribution to the cat prediction, which makes sense, right? Because the green part is basically the cat and the red part is basically the dog. So we can basically apply this method to the individual tokens in our in Prima, and I can just quickly show some results. So in each of these cases, on the left, we have these dotted line circled, like these are just manually circled, like where the tumor is or where the disease is actually supposed to be. And on the right, we highlight the most important tokens as determined by Lyme on each one of those. And like the most important tokens in red, the seconds in blue, thirds in green, and so on, right? And we do see that overall, like the Lyme visualization almost perfectly identifies where the diseases are, right? So for example, on the left here, we see that we have this medulloblastoma right here, and we're perfectly highlighting the tokens over this medulloblastoma. And same thing, we see the same thing here for this ependymoma case. And for this glioma, this very big one, we also have this, we just literally highlight the token that's right on top of it. Here's just some more examples. So these are no longer tumors. Here we have the hemorrhage case on the left, where there's this big hemorrhage here, and we are highlighting the tokens on top of the hemorrhage. And here we show the case of the arteriovenous malformation. Here on the right, we also a perfect match. And here for multiple sclerosis, we were able to find one of those, which is already enough for accurate diagnosis. So yeah, and here's just a few more examples on some other types of tumor, like medulloblastoma, well, ependymoma, and oh, actually, no, that's the old one. Here's just more tumors. Here's the meningioma case and a schwannoma case and lymphoma case, right? So all of these Lyme visualizations aligns very well with where the tumor actually is. And not only can we do this for the diagnosis prediction, we can also do it for the acuity prediction, right? So if the model says, oh, this guy has like medium acuity or this guy has high acuity, right? We actually get to highlight why we actually get to figure out why the model thinks so. Because for example, on the left here, the model thinks the person has medium acuity because they have cerebral small vessel disease as highlighted in these regions, right? And then on the right case, we see that the person has high acuity. The model thinks the person has high acuity because he has these subdural hematoma along like this edge right here, and the model actually the Lyme visualization actually highlights this part. So so yeah, and then so we actually do have a demo website right here that sort of showcases all of these. So if you're interested, feel free to go to prima.mlins.org, and you can just select a disease diagnosis, and then you can select the patient, and then you can sort of scroll through this, and then and then on the left down here, we're showing like the Prima prediction for diagnosis, and on the right, we show like the acuity prediction, and also we have the referral recommendation prediction from Prima. And here in the middle, we can actually see that the the tumor is supposed to be over here, right? And then like maybe this is two. Yeah, so we can sort of see that the tumor are Lyme visualization tokens are highlighted token are actually right above the actual tumor. So we also show like the Lyme prediction. So yeah, feel free to check out this this demo website. And okay. And yeah, for a second. So yeah,
Just one question, when you had that last slide with the squares, the line predictions, is it square because that's the slice of information that it has? And it's not necessarily
so
the shape of the tumor
so Lyme only, so basically what Lyme does is it assigns like an importance score to each token, and each token is 4 by 32 by 32, right? So
Yeah.
when shown on a 2D case, it will just be a 32 by 32. Right, so that's why all of these squares are 32 by 32. They're only like and then they have to align with like the 30 by 32 grids.
Sure.
It's because that's how we cut them up into tokens.
Okay, I just want to do a time check here. We are approaching the hour, so wrap up the next few minutes. That would be great.
Yeah, okay. Sounds good. So yeah, I'll be quick. So here we just show a quick clinical vignette. This is like a one patient. So on the left we have a study taken by the same patient but earlier, and then on the right it's like taken later. And basically this guy had a surgery early on, tried to remove a tumor, and then wasn't removed very well. There was like a lot of residual, but back then it was like sort of low grade. right? But then over time, this thing turned malignant and then became a high-grade glioma. So we do see that, like in this case, the Prima prediction on the previous study has a very low logit on high-grade glioma, but for the later study, the high-grade glioma logit just jumped up to 9.3, so it's over 10 times increase. And here's another clinical vignette where this guy had a brain abscess in an earlier brain MRI, and then this guy went through surgery to treat that, and then the abscess is gone. So the Prima prediction for the person before for the earlier MRI has a much higher brain abscess prediction than for the later MRI. Right. So these just shows how Prima actually applies well in these real world clinical cases. And so and remember before we talked about like there's like bias and turnaround time for within the health system, right? So with Prima, any brain MRI can be inferenced within seconds, and we hope it can assist radiologists and reduce overall turnaround time. But we want to verify whether Prima's performance and prediction accuracy is fair across these groups, right? So here's the prediction performance on Prima between each of these groups by population, by like population county, or by location of county, or by schedule, like whether you're taking on weekends or weekdays. We see that Prima's like across all of these groups, which means Prima is fair. And in addition to these shown in the slide, we also did the same analysis on across groups of divided by a sex, race, age, insurance type, MRI manufacturer, and assigned radiologist, and we basically find that Prima is fair across all of those. Okay. So yeah, since time's almost up, I'm just gonna go to the conclusions here. So in conclusion, I'd like to reemphasize our main contributions, which is first, we curated this massive 220K dataset. It's the largest collection of whole study brain MRIs with paired radiologist reports. And second, we present Prima, which is the first foundation model for whole study brain MRI with arbitrary 3D sequences. And it's done through VQVA compression and hierarchical vision transformer to make the model more efficient. And we've shown that it's trained on UM220K through clip objective with paired reports. We've shown that it has very strong performance on diagnosis, referral, and acuity predictions. And we do see that these predictions are trustworthy and they're visualizable via LIME, and that the performance is fair across patient group by various criteria. So yeah, at the end, I would like to thank my advisors for their guidance throughout this project, and I would also like to thank my collaborators for all of their contribution to this project. And yeah, thank you very much. So Prima is actually recently accepted in principle at Nature Biomedical Engineering, and so it should be published soon. And yeah, if you're interested, feel free to check out the preprint manuscript or the code repository or the demo website I just shown. Just scan a QR code and they should be there. And yeah, thank you very much.